Ma'am, you can start now.
Okay. Good evening and welcome everybody. So today is another lecture, pre-workshop lecture. It's on applied anatomy and sonoanatomy of muscles around knee joint. And the speaker is Dr. Priya Rathi. This is on behalf of Ashirvad Institute for Pain Research and Management, as you all know. The actual workshop will be conducted on 23rd, 24th and 25th of August in Nair Hospital. And the topic will be the role of muscles in various pain conditions and the relevance of ultrasound guided dry needling in relieving those pains. So let me introduce our speaker, Dr. Priya Rathi. She has done fellowship in chronic pain medicine from Ashirvad Ashirvad Institute of Pain Research. She is also fellow of Indian Academy of Pain Medicine. She is the director in Sigma Spine and Pain Clinic, Pune. Director, Chronic Pain Services, Asian Ortho Spine Clinic, and consultant to Sancheti Hospital, Manipal Hospital, Pune. Good evening, ma'am. So, over to you, Priya.
Good evening, everyone. So, just to understand my topic, I would like to start with one case wherein we can understand the significance of knowing muscle anatomy and sonoanatomy. So, I'm discussing one case of 58-year-old lady who was diagnosed to have knee osteoarthritis, and she underwent cooled radiofrequency ablation and PRP without any relief. So finally, she underwent total knee replacement. Post-surgically, she developed pain in new areas like outer aspect of knee and in chin of tibia, which is more at night. Now what next? So now to understand this case, we need to see what are the pain generators in knee joint. First and foremost would be muscles and tendons, then would be bones, ligaments, menisci, and bursae. Why I have highlighted muscles and tendons? Because muscles and tendons themselves can act as pain generators, and whenever bones, ligaments, menisci, or bursae are affected, then also it is going to get reflected on the muscles and tendons. Muscles are final common expressors of pain in any joint or nerve related pathology. Why so? Because there is one law called Hilton's law in anatomy, which says that nerve which supplies the joint capsule also supplies the muscles which regulate the movement of the joint and skin over it. So whenever joint is going to get affected, your muscles are bound to get affected by the joint pathology. The most common pathology which is being talked about is knee osteoarthritis, the predisposing factors being genetics or age and repetitive microtraumas. ACR defines osteoarthritis as any person who has aged more than 50 years, morning stiffness of less than 30 minutes, crepitus, bony tenderness, bony enlargement, and no warmth of synovium. So if all these criteria are met, then patient is diagnosed to have osteoarthritis. Now, if we look at the structural features which are being seen on investigations, that is osteophytes, cartilaginous abnormalities, subchondral cysts, bone marrow edema, subluxation of meniscus, and meniscal tear. But all the patients may not have the structural abnormalities. In fact, there is no correlation between the structural abnormalities and the amount of pain patient can have. So, this is the study which is being carried out in 2008, and it says that there is discordance between the radiological imaging and patient's symptom. So, very small group of patient can actually have radiological disturbances in knee pain patients. The other patients can have whole joint complex osteoarthritis, or there could be non-OA pathologies like tendinitis, or there could be some systemic diseases like cancer, referred pain, or osteoporosis, or some non-physical symptoms like depression. This study says that there is no statistical significance in WOMAC score in those who have knee pain but no radiological changes on X-ray compared to those who have radiological changes in knee osteoarthritis, radiological changes of knee osteoarthritis. So WOMAC score is being studied in all our patients who come to our OPD. We assess pain, we assess stiffness and functionality in patients who present with knee pain, so that we have some objective data at the end of our consultation and treatment. So if we talk about anterior knee pain, there can be a whole battery of the diagnosis. It could be because of arthritis, bursitis, jumper's knee, or patellar tendinosis. Osgood-Schindler disease, that is that occurs in patients of younger patients of growing age. Patellofemoral pain syndrome can be there. Chondromalacia patelli, that is degenerative changes in the patellar cartilage. Plica syndrome. So plica syndrome is a condition wherein the synovium overgrows, and whenever our knee flexes, ideally whenever our knee flexes, the synovium gets stretched, and whenever knee extends, the synovium gets relaxed. So in plica syndrome, there could be impingement of synovium while flexion and extension of the knee because of the overgrowth. So it can lead to either anterior, medial, or lateral knee pain. There could be cartilaginous injury, there could be tumors or nerve entrapments. If we talk about medial knee pain, if you remember the structures on medial aspect of knee, it could be because of the cartilage, it could be because of the bursae, or it could be because of the tendons and arthritis itself, or it could be some nerve entrapment like saphenous nerve entrapment. Very important cause can be L3-4 radicular pain, and this patient can be really confusing. Posterior knee pain, again, it could be because of the bursitis, Becker's cyst. Very important cause, it can be referred pain from facet joint and SI joint. There could be nerve entrapment, semi-membranous tendinopathy, biceps tendinopathy, and tumors. If we talk about lateral knee pain, it could be because of IT band, or it could be because of the bursa, fibular bursa, or it could be because of the lateral meniscus tear or lateral collateral ligament injury. Coming to actual anatomy, so knee joint is the largest synovial joint in the body, and it has very complex biomechanics. So it's a condylar joint between condyles of tibia and femur, and there is saddle joint between patella and femur. The movements which are possible majorly at knee joint are flexion of around 120 to 150 degrees and extension of 5 to 10 degrees. There are minimal internal and external rotation also possible at knee joint. Now, the actual joint, this is formed between the condyles of femur and tibial condyles, the lateral condyle and medial condyle. The size of medial condyle is quite more than the lateral condyle of femur. The condyles are being covered by hyaline cartilage. This hyaline cartilage prevents the friction in the joint. Now, tibial condyle is being covered by the menisci. If you look at the meniscus anatomy, the medial meniscus is larger in size because it has to accommodate the large femoral condyle, and lateral meniscus is smaller in size, and these two menisci are being joined by the transverse ligament of knee. The peripheral part of the meniscus is supplied by the blood vessels, whereas the inner aspect of the meniscus is not being supplied by any, does not have any blood supply. Now, coming to the cruciate ligaments, the anterior and posterior cruciate ligaments. Anterior cruciate ligaments originates from the intercondylar area, and it is attached to the lateral femoral condyle. The posterior cruciate ligament from intercondylar area to medial femoral condyle. It gives stability in anterior and posterior direction. Now, there are lateral collateral and medial collateral ligaments. These ligaments give stability in varus and valgus stresses. So knee joint stability is being given by muscles and tendons, medial and lateral collateral ligaments, anterior and posterior collateral ligaments, and iliotibial tract. Now there is very important concept in regarding biomechanics of knee, that is locking and unlocking. As we know that medial condyle of the femur is larger in size. So whenever we are trying to extend our knee, the lateral condyle occupies the lateral meniscus first and medial condyle then rotates medially considering the axis of the lateral condyle so that the knee is fully locked and during full extension. So this action is being carried out by quadriceps tendon. There is very small muscle known as popliteus. This popliteus helps in unlocking of the knee. So whenever we have to flex our knee from extended position, knee has to first unlock. And this unlocking action is being carried out by popliteus. So what does popliteus do? This popliteus will cause the lateral rotation of the femur during early flexion. So whenever this popliteus in spasm, patient can have locking like symptoms. So patient won't be able to flex the knee from extended position. And this mechanism is known as screw home mechanism. If we talk about bursae around the knee joints, to remember, there are 4 bursa anteriorly, 4 bursa posteriorly, 1 medially and 1 laterally. So 4 anterior bursa would be suprapatellar bursa, which is just behind the patellar tendon. Then there would be prepatellar bursa, which is just above the, which is just outside the patella. Then infrapatellar bursa, one is superficial and the other one is deep. If we talk about posterior bursa, one bursa underlies the lateral head of gastrocnemius, one bursa underlies the medial head of gastrocnemius. There is one bursa which underlies the bursa of semimembranosus. It is known as, it underlies semimembranosus tendon and it is known as no name, no fame bursa. The 4th bursa posteriorly, that is bursa under the popliteus. Medially, there is pes answering bursa and laterally there is fibular bursa, which is not, all the bursa are not shown in this image. So 4 bursa anteriorly, 4 posteriorly, 1 medially and 1 laterally. If we talk about knee joint actions, the action of flexion is being carried out by hamstrings majorly, gastrocnemius, and it is assisted by sartorius, gracilis, and popliteus. Quadriceps acts as an antagonist. Extension is being carried about by quadriceps femoris and tensor of vastus intermedius. I will be talking about this muscle in my next slides. The antagonist would be hamstrings, gastrocnemius, popliteus, gracilis, sartorius. Internal rotation by popliteus, semimembranosus, semitendinosus, sartorius, and gracilis, and it is antagonized by biceps femoris. Now, why do we need to know all these actions, their agonist, their antagonist? Because there is one concept called functional unit. So this functional unit includes muscles that reinforce and counter the actions and joint which are crossed by these muscles. So this interdependence is also reflected in the sensory motor cortex, and presence of trigger point in one group of muscle increases the likelihood of triggers in other group of muscles. And this explains why do we need to address agonist as well as antagonist in the any pain conditions. So muscles of front of thigh, it includes quadriceps femoris, the sartorius, and tensor fasciae lata. Quadriceps femoris, it has 4 parts. One is rectus femoris. It has 2 heads. One head arises from anterior inferior iliac spine. Other head arises from the groove above the acetabulum. So rectus femoris crosses hip as well as knee joint. There is vastus intermedius below this rectus femoris, and this vastus intermedius, it arises from the femur and it inserts on the patella. Vastus intermedius has anatomical connections to vastus lateralis. Vastus medialis, this muscle originates again from the femur, and the distal fibers of vastus medialis, they turn obliquely and they it has anatomical attachments to vastus, to adductor magnus, adductor longus, and medial intermuscular septum. This whole complex is known as vastus medialis obliquus, and some authors referred this to as vastus medialis longus. Then there is a huge muscle called vastus lateralis. So this vastus lateralis has anatomical connections to gluteus maximus and iliotibial band. The fifth contributor to quadriceps femoris, this muscle is being seen in some cadaveric studies. Clinically, we have never seen this. I mean, at least I have never seen this muscle on ultrasound. So it's the fifth contributor to quadriceps femoris. Separate muscle lies between the vastus intermedius and lateralis, and it attaches to the medial aspect of patella. Action is same as quadriceps femoris. If you see the cross section of the thigh, here is the femur. Just overlying the femur would be your vastus intermedius. Above that would be rectus femoris. Laterally, this big chunk of muscle is vastus lateralis. Medially, this is vastus medialis. If we go little medially from rectus femoris, there would be sartorius. Below the sartorius is adductor longus. This is adductor canal. The roof being formed by sartorius, the base being formed by adductor longus. Behind that is adductor magnus. Posteriorly, there is biceps femoris and semimembranosus, semitendinosus. So quadriceps femoris, the rectus femoris part of quadriceps femoris is known as two-jointed puzzler. Why? Because it crosses two joints. And why puzzler? Because triggers in proximal end of rectus femoris can give rise to deep knee pain or pain in the lower aspect of the thigh. Vastus intermedius is known as frustrator because vastus intermedius triggers cannot be palpated easily and it gives rise to very severe pain in the mid-thigh. Vastus medialis, it's known as buckling knee muscles. Many a times a patient comes with complaint of buckling of knee, but in MRI we do not find any tear in the ACL. So why does that happen? That is because of the weakness of vastus medialis. Vastus lateralis is known as tuck patella muscle because vastus lateralis, whenever there are many triggers in the vastus lateralis, it gives patients complain of as if the patella is stuck in one place. So trigger point referral areas. This is just pictorial representation. Such clinically, we do not see such clear-cut referral patterns. There are multiple referral patterns seen in one patient. But just to understand, this rectus femoris triggers can give rise to anterior knee pain. Vastus intermedius trigger point can give rise to mid-thigh pain. Vastus medialis, it gives pain in the medial aspect of knee. The pain due to vastus medialis is not very severe, but it just leads to it leads more to buckling of the knee. Vastus lateralis, this muscle can really give rise to confusing clinical picture because it can give rise to the lateral thigh pain. It can give rise to posterior knee pain. It can give rise to the pain in the upper part of the thigh, which can be very confusing with greater trochanteric bursitis. And when it gives rise to pain on the lateral aspect of the knee, it can be confused with IT band syndrome. So symptoms of rectus quadriceps trigger points could be rectus femoris trigger point will lead to rest pain and patient will have difficulty and weakness in knee while descending the stairs. Vastus intermedius, there would be difficulty in straightening the knee after inactivity and difficulty in ascending the stairs or change in position from sitting to standing. Vastus medialis will lead to deep pain in the knee. It will interrupt the sleep and buckling of the knee can occur. And vastus lateralis, as I said previously, that patient will have pain while walking. Patient will not be able to sleep on the affected side. There would be stiffness, there would be difficulty in the knee flexion and extension after prolonged sitting or immobilization, and it can be clinically confusing with GT bursitis or IT band syndrome. Now, muscles of medial compartment of thigh, major muscles are longus, brevis, and magnus. There is small muscle called pectineus. Some authors include it in front of thigh, some include it in the medial compartment, and there is gracilis. So this pectineus and adductor magnus are composite muscles because they have dual nerve supply. So pectineus is supplied by femoral nerve and obturator nerve. Adductor magnus is supplied by obturator and tibial part of sciatic nerve. Gracilis is the only medial thigh muscle which is not attached to femur. It is attached to the pelvis, and in the lower region it is attached to the tibia. So adductor longus has continuity with the vastus medialis, pectineus, rectus femoris, and capsule of pubic symphysis. Adductor brevis, it has continuity with the adductor magnus. Adductor magnus. Adductor magnus has three important parts. One is most anterior part, which is also known as adductor minimus. Then there is middle part and posterior part. Posterior part is similar to hamstrings, just that it does not cross the knee. Now, and pectineus, as I talked, is composite muscle, and gracilis, it crosses two joints. Now, if you look at the referred pain pattern of adductor longus and brevis, patient will have pain in the groin and medial thigh. Adductor magnus can really give very bad pain in medial thigh, and patient can have perineal pain and intrapelvic pain also. Gracilis also can give rise to medial thigh pain. Pectineus, groin pain. Now, symptoms could be groin pain while weight bearing, intrapelvic pain, anteromedial thigh pain, and difficulty in sitting cross-legged. Muscles of posterior compartment of the thigh. These are semitendinosus, semimembranosus, and biceps femoris, the two heads of biceps femoris. These muscles are known as hamstrings. What does hamstring mean? Hamstring means the meat from the back of the thigh. So all the hamstrings have four common characteristics, that all of them arise from ischial tuberosity. All are inserted into one of the long bones of leg. They all are supplied by tibial nerve, and all are flexors of knee and extensors of hip joint. Now, exception to this is short head of biceps. So short head of biceps is not included. Ideally, it is not included in hamstrings, though it is posterior compartment muscles. Adductor magnus. So adductor magnus is considered to be part of hamstring because the tibial collateral ligament, it represents the degenerated tendon of adductor magnus, and it is supplied by tibial part of sciatic nerve. So it meets the criteria of hamstrings. So hamstring is not used much during standing and walking, but it is very active during running, jumping, and climbing. That's why in the previous days during war, people used to injure the hamstrings of other people because so that they cannot run, or they would injure the hamstrings of the horses and elephants of the enemies. So that is known as hamstringing the enemy. Now, referred pain pattern of the hamstrings would be, if we talk about semimembranosus and semitendinosus, patient will have pain in the subgluteal region, and biceps femoris trigger points will lead to posterior thigh pain. So same symptoms would be pain near gluteal fold, buttock, or thigh or back of knee. It aggravates while sitting on the hard surface and getting up from sitting. So this picture can be very similar to ischial bursitis, and there would be sleep disturbances because patient won't be able to straighten the leg. Whenever patient tries to straighten the leg, the patient is going to have pain. So this is known as hamstring syndrome and high hamstring tendinopathy, which is easily confused with sciatica. The patient will complain of pain in the posterior aspect of the thigh, and so it's kind of confused with the sciatica. Now, muscles or at the back of leg which cross the knee joint are gastrocnemius, the medial head and lateral head. Deeper to that would be soleus. Here is the soleus. Deeper to that would be tibialis posterior. On medial aspect would be flexor hallucis, flexor digitorum longus and flexor hallucis longus. The only joint in the posterior compartment which would be crossing knee is gastrocnemius. So I'll be talking majorly about it. So this gastrocnemius medial head triggers will give pain in the medial arch of foot, and it can give rise to posterior knee pain also. And lateral head trigger points will give rise to pain in the posterior aspect of knee. So these patients will present with medial arch pain, and there would be pain at the back of knee while climbing steep slopes or rocks, or while walking on the slanted surface. And these patients can have nocturnal calf cramps. So soleus referred pattern. This soleus can give rise to pain in the heel. Picture can be very similar to that of plantar fasciitis. So this patient will have pain along Achilles heel and sole, and pain on taking first few steps in the morning. There could be deep calf pain, and as we know that venous pump in the lower extremity is soleus, so it will interfere with the musculovenous pump if there are triggers in soleus, and this will lead to edema in the lower extremity. Popliteus, though small but very, very important muscle, it will give rise to posterior knee pain. So patient will have pain while walking, running, going downstairs, and wearing high heels. There would be stiffness and difficulty in extending knee after long hours of sitting. Now, muscles of leg. If you see the cross section, this is tibia, this is fibula. Just lateral to tibia would be your tibialis anterior. When we go little more laterally, what we see is extensor compartment. In extensor compartment, superficial one would be digitorum. The deeper one would be hallucis one. Still lateral to that would be peroneus longus and peroneus brevis. Behind tibialis anterior would be your tibialis posterior, and medially, which is attached to tibia, is flexor digitorum longus, and laterally attached to fibula is flexor hallucis longus. Posteriorly, most superficial is gastrocnemius, and deeper to that is the soleus. So this will help in doing our ultrasound of the lower extremity. Now I have put the probe on anterior aspect of the thigh, mid thigh. Here, what you can see, the main chunk of rectus femoris, deeper to that is the vastus intermedius. When I went little medially, this is vastus medialis, and just which is the muscle which is attached to femur, directly over the femur, is vastus intermedius. When I go laterally, the big chunk of muscle is vastus lateralis. I've held the probe vertically just above the patella. This is the patellar tendon. This is the suprapatellar recess. It has direct connection with the knee joint. And here is the fat pad. I've kept the probe longitudinally, obliquely, just below the patella. What we can see here is the base answering bursa. Here we cannot distinguish each tendon separately, but if there is fluid collection, we can see it easily. Now, I have come little below. Previously, I had kept the probe on the mid thigh. Here, on the just above the patella, we can see that rectus muscle here is little smaller. Vastus intermedialis is bigger, and just this muscle is vastus medialis. Now in the leg, I've kept the probe just lateral to the shin of tibia. This is tibia. This muscle bulk is tibialis anterior. This is intermuscular septum. Below that would be your tibialis posterior. When I move the probe little laterally, what we see here is the extensor compartment. Here is extensor digitorum. Deeper to that would be extensor hallucis. Just above the fibula would be peroneus longus, and below that would be your peroneus brevis. So unfortunately, I could not put the picture of hamstrings and posterior compartment of thigh. Sonography pictures of those two muscles are remaining in this slide. That's it from my side. Thank you.
Thank you, Priya. That's really nice lecture. Very well explained anatomy and sonoanatomy. And any questions? No questions so far. Madam, would you like to add anything else?
Good talk, Priya, and a good explanation of all the muscles. One of the pains around the knee, which is not really, what shall I say, elucidated, is the tibiofibular joint. That can also give pains, quite severe pains, in fact. And this also leads to a lot of cramps in the peronei muscles.
OA
So that
tibiofibular
is one.
joint.
Yeah, OA of tibiofibular joint. In fact, most textbooks leave this out.
Yes.
But I'm seeing it in patients. Yeah, I think we look at other people's questions.
Madam, no
so
more
that
questions.
We can start.
No questions so far, I can see.
So very
Everybody,
clear explanations. That's why.
yeah, either they all know everything or they don't have. Priya has explained extremely well.
Yeah. See, Priya explained the combination of muscles, like the vastus medius goes with the adductor magnus and adductor longus, and the vastus lateralis goes with biceps. You know, these are all composite pains most women get. If you go into the details of what the women are complaining about, you will find that all these muscles are separately involved. I mean, when I say separately, when biceps is involved, vastus lateralis is involved, and probably also the vastus intermedius. This vastus intermedius is a huge muscle, actually. And it's initially, I never realized how big it was till I started seeing it on the sonoanatomy.
Ma'am, I remember one case where patient had knee pain, but it was radicular pain from L3-4. The lady from Indore, doctor's mother. So while I was reading this, I thought, yes, there are some textbook references, but we never see the details till we know the patient.
In
Yeah.
fact, my
Yeah.
latest, both knee pain patients have a spine problem, basically now compression at the spinal level.
No, in fact, knee pain and spine pain always go together. There are many patients who present with disc extrusions or prolapse or an annular tear, and they will be coming with mainly knee pain. And then there will be knee pain patients with very bad OA knee coming with back pain. This is because of the ground clearance. To achieve the ground clearance in OA knee, where the knee is unable to flex well, they keep the knee straight without moving it much, and the movement happens at the quadratus lumborum. So all OA knee patients will have back pains, and the back pain people, anyway, this is the area for the radiation of pain in
They will
back.
all over the thigh, they will have pain.
Yes, especially the lateral thigh, vastus lateralis and intermedius are always involved in facet pains. And unless these muscle pains are addressed, the facetal pains will never go, even if you have done the RF procedure. Even after RF, you have to do the needling of these muscles, the vastus intermedius and vastus lateralis.
Madam, there is one question. Priya,
Yeah.
post cooled RFA and viscose supplementation, how many needling sessions should we recommend?
Basically, in our practice, I recommend around 8 to 10 sessions of dry needling. But patient is being explained that 1 or 2 sessions here and there is acceptable. Usually, patients start showing relief after 3 sessions. So minimum 3 sessions to see the effect is what I say to the patient.
With a gap of how many days, what would be your...
Initially, when a patient comes, I tell them that we do it twice a week. Once patient gets around 50 to 60% relief, then the duration between the session is increased to once a week, and then we continue it every week till patient has good relief.
So you can't do all muscles at a time, right?
Yeah. So one session we do from the front, and one session we do from the back. So first session, when patient comes, I do of quadriceps femoris and tibialis anterior, and extensors if they are involved. And most of the patient, it is involved. So extensors and peronei are to be done. And posterior compartment, we do hamstrings and gastrosoleus and tibialis posterior.
Back muscles?
How can I miss out that? On the when I do hamstring, do back muscles also.
You have to do the quadratus lumborum in the first session itself so that the patient stops waddling and starts bending the knee.
Okay.
Many times the lateral thigh pain is also because of the long head of biceps. And many back of the knee pains are because of the gastrocnemius.
Popliteus is a hidden culprit in most of the cases.
In many cases. But it's so deep-seated that unless
it's within the
ultrasound, it's difficult to target it.
It's within the capsule posteriorly. It's little, I don't know. I've never done.
No, sometimes you have to do it in back of the knee pains.
Madam, but it's
you take.
It is quite adherent to capsule, I think. It's within the capsule.
Yes, it is. And you can see it on ultrasound. So unless you do that muscle, sometimes the back of the knee pains don't go. Though, most of the time, if you just do gastrocnemius and the hamstrings, that should do. But some patients won't respond unless you do the popliteus. You will have to visualize it and then
Madam,
do it.
There was one young lady with no history of trauma or injury or fall, severe posterior thigh pain, and when MRI was done by orthopedic, she had huge calcification on medial hamstrings. And they just said nothing doing, means only physio.
That is their always modus operandi, isn't it?
But patient had severe pain.
Must refer to physiotherapist.
But she was unable to walk, unable to stand.
Yeah.
So I did needling over there, and she was like, she got 30-40% in first session pain relief.
Yeah, they will get. See, even if it is calcified, if you release the rest of the muscle, the calcified area may still remain calcified, but the whole muscle starts participating in the movement.
Relax, basically.
Rather than one part of the muscle, maybe the calcified part only or whatever. So there is always going to be overall improvement. Sometimes catching the lateral hamstring, lateral gastrocnemius can be a little dicey because of the common peroneal nerve. It is so close to that area, needling that becomes difficult. And in many patients, elderly patients, the muscles don't look like muscles. They all look white. So they are, the muscle looks like nerve, nerve looks like muscle, tendon looks like nerve, everything looks like everything else. So it can be quite difficult in elderly patients.
Even
sometimes.
sartorius, for that matter, is quite fibrous in elderly patient.
No, in most patients, forget about elderly patients, post 45, 50, you always find, I'm always surprised if I find a black sartorius. Invariably, it's like a shining beacon of white. In fact, today only I was doing PRF for a patient who had had a knee replacement. She had such massive effusion in the knee, which means, she had a massive effusion in the suprapatellar bursa and also in the just over the tibiofibular joint. So that means in this patient, the knee has been replaced, but the muscular component was not at all addressed. So she was struggling with pain because of that. There is nothing wrong with the replacement, but the muscle problems which were there before the surgery were never addressed. Yeah. Anybody else has anything to say?
I can't see any questions here.
See, needling is also very useful in RA knee as well. Huh? Most RA patients, the rheumatological treatments will take care of the inflammatory component of RA, but the pain part of it does not get addressed at all. So these patients benefit a lot if they come for dry needling or come for PRF procedure. The whole OA has been discussed as a neuropathic pain condition. So that is where our type of PRF becomes very significant. When I say our type of PRF, we do not just genicular. In fact, I was not doing the genicular nerve PRF at all in the initial days. I used to do the femoral nerve, the saphenous nerve, the peripatellar plexus, the subsartorial plexus, the popliteal plexus, and the sciatic nerve, common peroneal and tibial. So this was my common practice. It was only later I said, okay, I might as well add genicular when everybody started talking about genicular and choice article got published. So why did I start off on this topic? I don't remember now, but whatever it is, the PRF takes care of the neuro component of the neuromyopathy, and the needling takes care of the myo component of neuromyopathy. The OA is considered as neuropathy, which is actually neuromyopathy. So this combination of PRF and needling helps a lot. And of course, there is going to be physiotherapy after that. That's very important. There is, I think somebody is asking a question.
In case of ligament or meniscus tear or injury, where and how should we proceed with needling? Priya?
So it depends on the degree of meniscal tear and not meniscal tear, but at least in ligamentous injury, I do consider the degree. If it is grade 4, I send the patient directly to the surgeon. Up to grade 1, 2, and 3, we can manage with needling along with other modalities like ma'am mentioned about PRF. Following PRF, we do dry needling session, again same 8 to 10 sessions of dry needling, agonist as well as antagonistic muscles at the knee joint. So first session we do at quadriceps femoris and anterior leg muscles. Next session we do hamstrings, back muscles and gastrocnemius and posterior deeper muscles, and such that 8 to 10 sessions are being needed for such patients.
You're talking about ACL and basically anterior cruciate, or you're talking about medial and lateral ligament in the patient?
No, not medial and lateral. Usually these patients, they land up with the surgeons only. I have never seen patient who has medial and lateral collateral ligament tear in my practice, but ACL tears I have been
I'm
seeing.
talking about injury.
Yeah, injury.
Is tear or injury, both.
Yeah, but
See, what is
ACL tear?
The medial collateral ligament has two components, superficial and deep. So deeper component has menisco-femoral and menisco-tibial component. So whenever there is a meniscal injury, invariably the medial ligament, the deeper layer of medial ligament always gets injured.
Yeah, true. But again, in those cases, it depends how severe is the injury. If there is crush injury of the meniscus, we cannot do much about it. For the grade 1, 2, 3 injuries, we can definitely reduce the stress on the joint by doing dry needling.
Usually we'll end up seeing these meniscal tears and all long after it has happened. In the sense, the patient might have gone to the arthroscopic surgeon. When the arthroscopist says, look, you need to undergo arthroscopy, the patient refuses and then continues like that only. They rest a little, or rest a few days, get a little better, but they will be stiff and there will be compromises, but they continue like that. Then they'll end up 1 year later or something like that with us. And by which time the nature actually has healed the meniscus. And but the meniscus might have healed, but the response to the meniscal tear of muscle spasms and myofascial triggers, which have been generated at that time, they haven't gone. So to address those, if we do the PRF and needling, very good results in these patients. Late presenting meniscal tears. In the early phases, I think if it is better that if there is a tear, it's better that a arthroscopic surgeon or an orthopedic surgeon sees the patient and then tells them, look, no surgery or something like that. It's better that way medico-legally. And then we can address the patients. There again, a combination of PRF and needling may help, or just needling may help in these patients.
Okay. Another message. Do you add PRP also? Intra-articular PRP. Somebody has asked about PRP.
In grade 1 and 2 cases of osteoarthritis, we can consider PRP along with dry needling.
Now for meniscal tear, they're asking, or OA? I'm not getting. Hello? Who has?
For tear, she's asking. See, for meniscal tear, usually in patients of OA, if we do MRI, there is going to be meniscal tear.
PRF of which now did you consider, madam? Priya?
Yeah.
Priya.
So for knee osteoarthritis, we do composite PRF like PRF of femoral nerve, saphenous nerve, peripatellar plexus, subsartorial plexus, and sciatic nerve. That is how we tackle patients of knee pain. And there is one wonderful article published by Vas ma'am on PRF. I follow that protocol.
Good evening, ma'am.
Yeah, tell.
Actually, ma'am, I was only asking about PRP. I have some
Yeah.
doubts. One, I missed the answer of PRF, which Dr. Priya gave just now. Which nerve did you say? Sorry, I missed it.
So we do femoral, the
Mhm.
saphenous, peripatellar plexus, subsartorial plexus, and saphenous nerve.
Okay, your-
Posteriorly, we do sciatic nerve.
the protocol ma'am said some time back. Okay,
Yes, yes.
okay.
It's
And
this article is being published.
okay, okay.
No, it's already been published many, many years ago, and it is all the details are available.
Okay.
In fact, there are two articles which describe this PRF. One in a, ONE patient and one in a post-surgical pain. See, post-TKR pains are very, very troublesome. And in fact, I started studying knee pain because of the post-surgical pain, post-TKR pains. I started treating these patients. I developed this PRF technique based on an article by Horner Dellen, who describes the nerve supply of the knee, the entire nerve supply of the knee. So it is not just the genicular nerves that supply the knee joint, but it is the other, there are many other nerves which come, like there is a deep cutaneous nerve of the thigh, medial cutaneous nerve of the thigh, the saphenous nerve, the in fact, basically femoral nerve comes in because the knee is moved by the quadriceps mainly. And the quadriceps receives its nerve supply from the femoral nerve. And the hamstrings, which form the posterior complex muscles, they are all supplied by the sciatic nerve. So unless you address these muscles and the nerves that supply them, you are not going to get a good pain relief. Just thinking of the knee as a joint is not very realistic, because it is not just the knee, but the whole composite structures around the knee, and then the person with the knee, with the involvement of the spine and other things, which is referring pains to the knee also. And then, of course, the person with the mind as well. So you need to look at the whole situation, as you have to address the whole person and not just the knee. When you do just genicular nerves, you are sort of making your view like this. You don't see all the other problems in this patient, which are relevant to the knee pain.
Another question.
Probably that
Okay, continue.
in some of my cases where I do genicular RF, the effect is like less than 100%. Sometimes it's 80, sometimes 50 also. When it has been done correctly, still the pain relief is not up to the mark in some patients.
Yeah, that is because genicular nerve is only supplying the joint. And you need to look at all the structures around the knee. Only then you will get good results.
Yes, ma'am.
Yeah.
There's another question. Madam, what's your opinion about intra-articular ozone?
Priya, you want to answer?
Ma'am, I don't have any experience with ozone as such.
Okay, this thing is very useful. Ozone is very useful. Intra-articular ozone, but it is temporary. It may last about a week or 10 days. And if you optimize this time by doing needles, things become quite okay then. But if you don't optimize it with needling, it's a temporary effect. And I am not very certain about the effect of ozone on the intra-articular structures, because ozone can be quite corrosive when you look at it. You see, if the ozone touches the rubber of a glove, it literally melts, the rubber melts. So I really do not know what this ozone can do to the joint structures. And I don't think there is any specific study about it. So I'm rather wary of intra-articular ozone. And ozone surprisingly seems to have a local anesthetic-like action. And that is the reason why it provides pain relief on ozone injections. So to get that local anesthetic type of action for about a week or 10 days, can we subject the knee structures to ozone repeatedly? I'm not very sure.
Another question, in group 1 and 2 OA, what is the first line, PRP and USGDN or PRF with USGDN or just USGDN?
Okay, so like I had mentioned in my presentation that there is discordance between X-ray findings and patient's pain. So what the treatment modality will depend on the patient's pain. So if patient's pain is mild to moderate, we can only consider dry needling, ultrasound guided dry needling as the sole modality. If patient's pain is more than say 5-6, then we can consider pulsed radio frequency along with ultrasound guided dry needling. And yes, PRP is also a good choice. So, but PRP won't help much in pain relief immediately. Maybe in long run it will help.
See, you are looking at two components of the OA-knee. One is the damage from OA-knee, which the PRP is expected to heal, the growth factor concentrate or the PRP by adding, the growth factors only. Whether that will look towards the healing of the OA, the osteoarthritic component. And PRF and needling go towards healing the pain, improving the movements and other things. And by reducing the, friction of the two bones on each other. You see, when you do dry needling of the muscles which are stretching across the knee, the two bones are going to move apart like this a little. So that really is something like a curative situation. But that having been said, even with the relaxation, allowing the tibia and femur to move apart, you still need healing. And that is where I believe PRP has a role. So we can look at these things in first relieve the pain. And during the PRF, we do give steroids. So it might be advisable to wait and then do a PRP later at a later date. But what I have seen in my practice is after PRF and needling, the patient is so comfortable and so much more active that they are not ready to spend money on PRP after 1 month or 2 months or whatever it is. So though I tell them, look, healing is an important thing, they are like, okay, I will come back if I have any problems, kind of things. Yeah.
Can I ask a question?
Yeah, sure.
So you consider, see, the patient basically comes for pain. And so initially, would you offer PRF as first to relieve the pain and then think of PRP in such cases? Because PRP, as Priya said, doesn't really relieve the pain immediately.
No, I would totally agree with that. I wouldn't, if I went as a patient, I wouldn't want PRP. I
Correct.
want pain relief and I want stiffness to go. I want to start walking properly. After all these things are achieved, and then we can look at the healing effect of PRP later.
Priya,
First, and then do healing.
There is another question. Many patients come to my clinic who have grade 4 OA, not willing for surgery. Will USGDN and PRF relieve pain for a considerable time?
Yes, it does. I have a small series of patients who definitely did not want surgery. And they were, in spite of my telling that, look, you are in a good shape, why don't you go for surgery and all that, they say, no surgery for me. If you can make me better, you do it. And so these patients do quite well. Some of them do very well, but some of them don't. Few of them don't. So it's like in a severe ONE, you have to explain this to them and then go ahead with the procedure. Once they understand that there is a good possibility of pain relief, but not the whole pain relief. And sometimes you see you are adjusting you are tensioning across the knee. Sometimes patients would have settled in a particular abnormal equilibrium, which allows them to be fairly comfortable, but certain movements are difficult. In such patients, in one such patient, I have this experience where I did a PRF and he said, look, before PRF, I had no continuous pain, but after your PRF, I have continuous pain. So there is a possibility like this. And he was not one of those secondary gain or unnecessarily complaining kind of patients. He was quite an objective person, but he's the only person who complained of pain after PRF, as a negative effect of it. So I told him, sir, you must have been happy in your own equilibrium, though you had severe ONE. He had replaced one knee, and the second knee he had not replaced. And that was what was bothering him.
Madam, so many times we
So,
see distorted anatomy completely.
yes, distorted anatomy.
Lateralization of patella, and when the pain is gone, then they try to walk in a different way. So all the muscles which are not used to for that kind of a movement, the
Yeah.
tibia points develop in that.
So, but despite all this, I have not seen a worsening of pain. This was the only person who reported worsening of pain. In all these years, see, I have been doing this procedure for more than probably 15 years now. And in all these years, I've never had anybody complaining of a worsening of pain except this patient. So, I mean, you learn. As you go along, you learn a lot. But most patients, even with severe ONE, they do quite better.
So functional manual therapy will also have an important role in such cases?
Definitely, yes. After we do our needling, functional manual therapy can do wonders. And see, manual therapy is a very soothing and nice treatment, unlike needles, which is not a pleasant treatment. So manual therapy, 100%, I would endorse it. But one should know how to do it properly, that's all, to get the full benefit. Even improperly done, it will give you benefit, but properly done, it can work wonders.
One thing I would like to add is in grade 4 ONE who have varus and valgus deformities, extreme varus valgus deformities may not respond to our treatments, but at the same time, they may not respond well to surgery also, because surgeons would also not dare to touch such patients. Or they will they'll say that, okay, I'll correct it, but pain jayega ki nahi, ye nahi pata hai. So it's better give a chance than just denying the treatment of grade 4 ONE as per books.
Do you people remember that our free patient? What is her name? I'm forgetting.
I remember that maid.
Maid. She is like, her knees are like full varus deformity and all that. But she is managing to be pain-free with such a severe deformity. I mean, this is a lady we are discussing who's a very poor lady. And we treat her free anyway. Archana Surve, yes. Varsha has provided the name, Archana Surve. So this lady has been with us, And she comes maybe once a month or something like that now. Initially, we did a PRF as well as needling for her properly for about 10 sessions. Then she recovered significantly. Her problem was she had a mentally retarded daughter whom she had to carry to take her to the retarded school, and she had to take her in a bus. That was her problem. I can't lift this child and get into a bus. So we made her able to do all those things. And now she is like, it is only a question of remaining pain-free. Though she, if you look at her, everybody will be horrified at her walk and other things.
Okay, are we done?
I believe so.
Thank you, madam. Thank you, Priya, once again. It was a nice lecture. Okay, so shall I call it for a day?
Yes.
Yeah, thank you. Thank you, everybody, for adding to the discussion. And thank you, Priya, and thank you, Madhavi,
Thank
for
you.
conducting this so well. Thank you.
Thank you.
So much, ma'am.
Yeah.